بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين سيدنا محمد صلى الله عليه وسلم. Good morning everybody. Our section today is about the toxicity of snake bite. Only about 5% to 10% of snake bites involve venomous snakes. Only from 5 to 10% of snakes are only toxic in nature. Classification of snakes in Egypt. Venomous snakes belong to three families or three groups or three subtypes. The first is the subspecies elapidea, which produce neurotoxic snake venom, and the best example for this group is the Egyptian cobra. A second group is the subspecies vipreadea, which produce vasculotoxic snake venom. The third species or the third subgroups are the hydrophidea or sea snakes. It's called hydrophidea or sea snakes, and these groups produce myotoxic snake venom. This is the mouth of the snakes. The teeth of the snakes. The toxic snakes contain two rows of teeth, and the canine of the toxic snakes are large in nature, large, modified, and canalized, and it's called the fangs of the snake. This is the modified canine tooth. This canine tooth is very large on both sides, modified and canalized, and this canal is connected to an accessory sac, and this accessory sac is connected by another gland to the pituitary gland of the snake, which is the source and the factory of the snake venom. So the snake venom transmitted from the modified pituitary salivary gland to the accessory sacs, and at the type of fight, the snake is ejected from the accessory sacs to the canine to catch and bite its prey. So this is the fangs of the toxic snakes. The non-toxic snakes doesn't contain any fangs. This is a picture of the Egyptian or the Indian cobra. The Egyptian or Indian cobra is the only snakes which can stand from the ground, as you can see, and its face become swollen at the type of fight or catching its prey. And this Egyptian cobra is the only snake which can push its venom at a distance of or its spit at a distance of 3 meters, and can reach the human or can reach its prey. So this is the Egyptian cobra, as you can see. The snake venom is the saliva of the snake. It is ejected from a highly developed secretory organ, which is the modified pituitary gland, during the act of petting. It is faint, transparent, yellow, and viscous when fresh. Its content is proteinaceous in nature, most of which are glycopolypeptide and are enzymatic in action. About 80 to 90% of vipreadea and 25 to 20% of elapidea snake consists of enzyme. As you can see, many enzymes are present in the snake venom, like fibrinolysin, proteolysin, hemolysins, agglutinins, coagulase, phospholipase enzyme, cholinesterase enzyme, neurotoxin or neuropeptides, neuroamines, thromboplastin, cardiotoxin, hyaluronidase, and lysosinase enzyme. So the most of the content of the snake venom is proteinaceous in nature, and it has glycopolymorphide and has enzymatic action. As regards the pathophysiology of the snake bite or the snake venom, the neurotoxic snake venom produce paralysis or has curare-like action, produce paralysis of the skeletal muscle. The vasculotoxic snake bite produce hemolysis, intra and extravascular hemolysis, produce destruction of the blood element and the small blood vessels. Myotoxic or the sea snake, myotoxic snake venom produce destruction of the skeletal muscle fiber and produce muscular pain and weakness. As regards the action of the snake venom, the toxins or the neurotoxin binds reversibly to a presynaptic nerve ending of the peripheral nervous system and also to the cranial nerves. It is to the motor end plate or the myoneural junction and enter to the acetylcholine vesicle, as you can see in this picture, produce coating of the acetylcholine vesicle, preventing the acetylcholine from going to the synapse and also to the postsynaptic receptor at the motor end plate. So it produces coating of the acetylcholine vesicle, preventing the acetylcholine from performing its action on the postsynaptic motor end plate. Also this binding is reversible in nature, in contrast to the binding of the botulinum toxin. The botulinum toxin produce irreversible binding to the acetylcholine vesicle, while that of the snake venom or the toxins of the snake venom binds reversibly to the presynaptic nerve ending at the motor end plate of the peripheral nervous system and the cranial nerves. This is a picture of very large and huge snakes, as you can see. As regard to the clinical picture of the snake, we have local action at the site of the bite and systemic manifestation. The local signs at the site of the bite, it's called fangus marks. The fangus, which is the modified canine tooth of the snake. A bite from neurotoxic elapidea snake are very mild, hotness, mild redness, mild swelling, while the bite from the viper snakes and vipreadea produce marked local manifestation, marked redness, severe swelling and severe hotness, marked and progressive severe pain and bruising at the site of the bite or the site of the fangs. This is the characteristic sign of the fangus, as you can see. The fangus two dot-like bruising of the fangus of the snake, as you can see in this picture, and also this is the picture of the snake, while this picture on the upper left is not signs of the fangus. It is only splashing or licking by the teeth, and this also not a fungus sign. So you must look and search for the site of the fungus to diagnose the toxic snake venom. This is a picture of marked local manifestation of viper snake bite. There is marked hotness, marked swelling, marked bruising and hemolysis. Here there is severe bruising and hotness, redness and swelling, and there is also progressive marked severe pain at the site of the bite. As regards the action of the snake venom, the toxins or the neurotoxin binds reversibly to a presynaptic nerve ending of the peripheral nervous system and also to the cranial nerves. It is go to the motor end plate or the myoneural junction and enter to the acetylcholine. The acetylcholine vesicle, as you can see in this picture, produce coating of the acetylcholine vesicle, preventing the acetylcholine from going to the synapse and also to the postsynaptic receptor at the motor end plate. So it produces coating of the acetylcholine vesicle, preventing the acetylcholine from performing its action on the postsynaptic motor end plate. Also this binding is reversible in nature, in contrast to the binding of the botulinum toxin. The botulinum toxin produce irreversible binding to the acetylcholine vesicle, while that of the snake venom or the toxins of the snake venom binds reversibly to the presynaptic nerve ending at the motor end plate of the peripheral nervous system and the cranial nerves. The Egyptian cobra or the Indian cobra, as I told you, is the only snake which can stand from the ground and swell. Its face and the upper body become swollen, as you can see, and it has the ability to spit its venom at a distance of 3 meter, and this venom or this spit may enter in the eye, produce what is called snake venom ophthalmia. If the spit venom enters the eye, there is immediate and intense burning, stinging pain, followed by profuse watering of the eye and with production of white discharge, congested conjunctiva, and also produce spasm and swelling of the eyelids, produce photophobia, and this may be complicated by secondary infection which may lead to endophthalmitis or even panophthalmitis and blindness. So take care from the Egyptian cobra. The second group is the vasculotoxic snake venom or the viper snake or the subspecies vipreadea. Subspecies vipreadea produce snake venom which is vasculotoxic in nature. It produces destruction of the small blood capillaries, small venules and small arterioles, and also produce destruction of the blood element. So the local manifestation is marked and severe. There is intense local pain, swelling, ecchymosis, oozing of hemolytic blood, and blisters and bruises, contusion. Also there is petechial hemorrhage and systemic bleeding. There is intra and extravascular hemolysis, and there is also the hemoglobin descending unit produce what is called hemoglobinuria. There is some sort of nausea, vomiting, collapse. The patient may be collapsed with cold clammy skin, rapid weak pulse, dilated pupil, followed by loss of consciousness and death. And the cause of this here is the hypovolemic and hemorrhagic shock. This is a picture of what is called compartmental syndrome. The whole upper limb, as you can see, is hot red and full of blood, full of hemolytic blood, will reduce what's called compartmental syndrome, which constrict the large blood vessel, and they may carry the risk of gangrene and necrosis of the peripheral digits. The limb may swell to twice its normal size within the first few hours. Hypovolemic shock and the local compartmental syndrome may occur secondary to fluid and blood sequestration in the injured area, which is called compartmental syndrome. This results from circulatory collapse and hypovolemic shock. This is a picture of marked local manifestation of viper snake bite. There is marked hotness, marked swelling, marked bruising and hemolysis. Here there is severe bruising and hotness, redness and swelling, and there is also progressive marked severe pain at the site of the bite. As regards the investigation, the arterial blood gas to assess the electrolyte and acid-base disturbance. Baseline general investigation like CBC, serum electrolyte, coagulation profile, serum bilirubin, urine analysis, creatine phosphokinase, ECG, and chest radiograph. As regards the treatment, the first is the ABCD approach, or the emergency treatment, the first aid measure, and the time of the bite first, and the most important thing is allaying anxiety and reassurance of the patient, allaying anxiety and fright, immobilize the bitten extremity and transport the victim to the emergency department. Measure and record the circumference of the bitten extremity to diagnose the degree of swollen and the possibility of compartmental syndrome. Clean the bitten area, remove any constricting clothing and jewels, broad spectrum antibiotic, and give tetanus toxoid or tetanus prophylaxis. There is first aid measures which are dangerous and not recommended at all. The first is the constricting band or the tourniquet. The tourniquet is obsolete nowadays, and the tourniquet is out of medicine because it carries the risk of necrosis and ischemia of the peripheral digits. Also, incision at the bitten area carries the risk of infection and bleeding. Also, the oral suction of the wound also carries the risk of infection and carries the risk of toxicity to the person who suck the wound. Also, ice and the cooling of the bite carries the risk of ischemia and necrosis. Electric shock to the bite side also carries the risk of electrocution. Emergency and supportive measure: monitor the vital sign at frequent interval for at least 12 to 24 hours. Give good supportive care with respiratory, cardiac, and neurological monitoring. Maintain patent airway. Establish intravenous line intubation. Mechanical ventilation if needed for respiratory insufficiency. As regards the antidote therapy, in Egypt we have a good anti-venin or anti-snake venom, which is effective against the 6 species of poisonous snake. So it is called polyvalent anti-venin or anti-snake venom. It is available in the form of vials containing 10 ml of a colorless or pale yellowish solution. The patient must be in intensive care unit. The antivenin is administered by intravenous infusion, and the skin sensitivity test for horse serum should be done. The initial dose of the antivenin therapy based on the severity of symptoms, not on the body weight. As you can see in this table, if we have no manifestation, so no treatment. If we have mild manifestation, give 5 vials of antivenin. Moderate manifestation, give 10 vials of antivenin. Severe manifestation, give from 15 to 20 vials of antivenin. And there is no upper limit for the antivenin numbers of the vials. If the paralysis is present, give antivenin, and there is no upper limit for the number of antivenin vials. The end point of antivenin therapy is the reversal of systemic manifestation and halting the progressive edema and pain. If there is manifestation, give antivenin. No manifestation or no paralysis, stop antivenin therapy. So as long as there is paralytic or vasculotoxic manifestation of the snake venom, we give antivenin with no upper limit of the number of the vials. After that symptomatic manifestation, treat severe coagulopathy with fresh frozen plasma, fresh blood transfusion, packed RBCs, platelet transfusion. Treat hypotension first by crystalline fluid. If no response, give colloid. If no response, give whole blood. If no response, give vasopressor therapy. As regards the rhabdomyolysis, give sodium bicarb to wash the proximal convoluted tubule and wash the kidney from the rhabdomyolysis. Case number 1. 45 years old male patient was brought by his family to the emergency hospital toxicology unit complaining of difficulty in breathing, also difficulty in movement and difficulty in swallowing. About the toxicity of snake bite. Patient presented with blurring of vision, ptosis, lip hypoesthesia, sore throat, dysphagia to both solids and fluids, severe cough on any attempt to drink, hoarseness of voice, and dyspnea. The patient was fully conscious, pulse 100 per minute, blood pressure 120 on 90 millimeter mercury, temperature 37.5 degree, respiratory rate 30 per minute, and it is rapid and shallow respiration. The pupils were dilated, regular, equals in both sides, and with sluggish reaction to light. There is descending muscle paresis with generalized hypotonia and hyperreflexia all over the body. Local inflammatory sign at the site of the bite in the form of hotness, redness, and tenderness. What is your diagnosis of this case? Neurotoxic snake venom, a toxic snake bite by neurotoxic snake venom, or elapidea, or cobra snake. What are the investigations that should be done? The most important is the ABG to assess the respiration, assess the acid-base balance, and assess the electrolyte. And also baseline general investigation should be done. Arterial blood gases was normal. Serum pseudocholinesterase level was normal. 2325 international unit per liter. To differentiate and exclude the organophosphorus or pesticide poisoning or exposure to organophosphorus or organonitrogenous compound. What are the lines of treatment? The patient was put on hemodified 100% oxygen mask at a rate of 10 liters per minute. Intravenous line was introduced on each side, and the patient was admitted to the ICU for continuation of therapy of antidotal therapy, treatment of the snake toxin with cardiac and respiratory monitoring. Now we end the discussion of the toxicity of the snake bite. Thank you for all.